So welcome and good morning to everyone. My name is Michael Kennelly. I'm a practicing urologist from Charlotte, North Carolina in the United States. And as we've touched upon, one of the key areas when we're dealing with patients who have neurogenic bladder with intermittent catheterization is urinary tract infection. As was stated before, 2.7 times a year, patients have UTIs. Now, there's many factors that go along with that. And what we want to do during this session is with some of my colleagues is kind of have an open discussion dialogue. And when we do that, we're actually going to involve you. So we're going to bring you in, and there'll be times where we're going to poll and ask questions, and we'll get to that. But I think the key aspect is, remember, we're here to try to improve the patient's lives. Bobis, I wonder if you can take us through kind of patient factors, which are really sort of adherence, compliance. Are there anything that patients are doing that may themselves put them at risk?
I think that, for example, our patients for sure is not very compliant to the program because he's catheterizing 3 times and he has also leakage. So the voiding, how frequent will be the catheter insertion, how frequent they void the bladder, and the fluid intake can be a picture, a coin with 2 options. On one hand, if we do not do enough frequent intermittent catheterization, maybe we have a bladder over distension, or maybe we have exposure of the bladder in high pressures due to reflex volumes. If we decrease the fluid intake as a protection meter that they suppose that they will do it, we result in high osmolarity of the urine and the high concentration of the microbes there. So it's more often to have UTIs from that. On the other hand, some other condition has to be with a hygiene procedure. Patients at the beginning are very, very, very careful. Maybe they are more careful than it is needed, but during the time, they are performing catheterization very easily, but sometimes they forgot to wash hands, for example. Another issue has to do with the compliance is to see if there is a post-void residual, if they empty the bladder, of course, and it was mentioned by Nikes again. And you think there are some other issues that maybe as a healthcare providers we cannot change. We cannot change the healthcare system, or we cannot change the civil conditions in every part of our planet. But as a civilians and as a citizens, we have to push our governments, our politicians to improve the quality of the healthcare that every country provides to its citizen. So in our patient, for sure, we have to increase his fluids, to put more often in intermittent catheterization. It is proven that less or more, we have to find a balance between the fluid intake and the emptying of the bladder. And of course, we have to evaluate his technique, how you do it. I want to see you. Sometimes these patients say, oh, I'm doing that for 10 years, I know. But you have to reevaluate it and see him how well it is doing. And sometimes we will find very interesting issues. Okay?
So I think in regards to this patient, you brought up some very good points. One would be, I would sort of look at what is his volume intake and what is his catheterization. So a frequency volume chart. That's a very simple thing to do. You're asking the patient to get sort of compliance, to get an assessment. As you said, he was only catheterizing 3 times a day. Do you find that that would be beneficial in your practice? Do you use a frequency volume chart?
I use frequency volume chart in every patient because not only to evaluate them, but also to have a self-evaluation. I think that education of the patient, not only in general how to deal with his paraplegia and how to deal with his or her neurogenic bladder is very important, because if the patient is well educated, he knows when he has to evacuate the bladder, he knows when he has a true UTI. But of course, if you have a frequency volume chart, even the patient said that, okay, I'm drinking a lot, but if you see the records, maybe he's drinking less than a liter. So he starts also to adapt. So he can improve his way. I see, sometimes I advise patients, write down, do what I recommend, write down again and come to discuss. And usually they come and say, now I'm okay.
Yeah, and I think that the frequency volume chart is really a key aspect, and that's because number one, you're going to identify two things. One, what is his volume intake? So you'll get an assessment, are they drinking enough or not, and you can educate and counsel. The second aspect is during those catheterizations, I'm getting some assessment of what his bladder volume is. If he's catheterized and the volume maybe 600, and he's still leaking, then I know he probably needs to catheterize more frequently. If, on the other hand, his catheterization volumes are 200 or 225, then I'm a little bit worried that his high pressures and his oxybutynin that he's on may not be sufficient. And so to just randomly make a change, I want them involved because that's going to help in the educational process.
I think that we have to share the responsibilities. Our responsibility is to establish a bladder with good capacity and low pressure. And the patient's responsibility is to handle in a proper way to his bladder.
And I think the other aspect that I like using the frequency volume chart is that depending on their voided volumes or their cath volumes, that will guide me, if I do urodynamics, to kind of make sure that we're going to that volume. Yeah. Because traditionally at nighttime is when a lot of the patients will have an overproduction of urine, nocturnal polyuria, and sort of superdistend. Nikesh, in your practice, do you kind of look at frequency volume charts and base urodynamics off that, or?
I do, absolutely. Frequency volume chart is a part of urodynamics. It's part of its assessment. But you use the word simple, in fact. Have you ever done a frequency volume chart yourself?
I have.
It's not easy.
At nighttime, it's very difficult.
It's difficult. It actually takes a lot of time out of your day. To get an accurate frequency volume chart is not easy. We often give them one with 7 days on it. It usually comes back with maybe 1 or 2 days completed. So it is a very important aspect, but it's difficult to use. I wouldn't say it's simple.
But even for 3 days, and even if you lost some records, you can have the main idea.
No, I agree.
You agree?
Michael, I would like to bring another aspect. I believe we all agree that education of our patients is one of the cornerstones of successful bladder management technique. And nurses, occupational therapists, physicians putting a lot of efforts. But we have to remember that sometimes actually when patients hear from his or her peers, person who is on wheelchair, is absolutely make a big impact. And idea that was delivered person who doing catheters themselves is sometimes making much bigger impact than all our educations. That's why peer support is a very, very, I believe, crucial aspect to be involved and to help us to communicate with patients for the good educations and good compliance.
Well, I think that part of what you're seeing too is that if someone has a localized area, when someone has a urinary tract infection, we must always think of, oh, it must be the bladder. But what we've sort of uncovered and we've kind of peeled back to the onion is that there's really many other things that are out there. And to your point, involving everyone that's part of the healthcare team has their role. So even the physiotherapist, the occupational therapist kind of have an assessment. There are many, many risk factors other than just the catheter or instrumentation. As you go through individually, the general conditions, looking at diabetes, looking at their overall health. We didn't really talk about the female aspect of things regarding postmenopausal females with possible use of estrogen, but various things to look into. The local conditions, whether they're stones within the bladder, whether they've got thick-walled ischemia within the bladder, other things of their technique, educating within that process of the proper catheters of using it, and then also education of the patient. These are all factors that really take, as we've said, a holistic approach to really optimize the patient's use. What we've been able to accomplish is become a holistic approach. I mean, that's what we all want. We want to use kind of a holistic approach to try to improve the quality of lives within our patients. And I think that's what kind of this forum is setting up. This is what we're starting to do and getting everyone together. And so the next day and a half, we're going to be really focusing in on that. So I'd like to thank my panel for their comments, guiding me through this.